Hey, gang. We will do the quiz first, then we will dive in. Good? Okay, folks, can you hear me? Taya can hear me.
Yes, I can hear you.
You can hear me. Haley, can you hear me?
Yeah, I can hear you.
And Olivia, can you hear me?
Yep.
All right. Feeling better, Olivia?
Not really. My hearing's still like not there at
Sorry to
all.
hear that. Okay. We'll do the quiz first, then we'll get started. So at 7, we're going to go ahead and get started. So it's a skeleton crew here. So, yeah. So hold that thought. Everyone's ready. Thank you. We're all gone. They've all left Canada, so. It's a lot of voice in the building. Huh? Oh, QW means once a week. QW means once a week.
Yeah. I could not hold it. I was done.
Oh,
Yeah, and I'm like, double. Oh, sorry. That was my doing. I didn't put in the flag.
All right, so last time we were looking at the inhaled steroids. Many of these are just used as inhaled steroids. Their half-life is short, so the amount of systemic absorption is not terribly high. And I'd like to draw your attention, please, to one of the inhaled steroids. Yes, the one at the bottom of the inhaled steroids, it says seclisinide. Seclisinide is a specially formulated inhaled steroid that is degraded by enzymes in the lung. So this particular drug never gets out of the lung. Therefore, the amount of systemic absorption is very, very poor. So this particular drug is found to have no systemic side effects whatsoever. Now, of these, triamcinolone, if it gets absorbed systemically from the lungs, which it can, that can cause systemic symptoms, as can budesonide. In fact, budesonide, when we get to inflammatory bowel diseases, we'll see is used as a treatment. Doesn't tend to pass through the bowel terribly well, so you don't get a lot of systemic symptoms. But when you start to use these drugs at high dose, and depending on your symptoms, you can use a low dose, intermediate dose, high dose. At high dose, you'll start to get systemic symptoms. And the symptoms of long-term corticosteroid use, of course, are manifold, and they're not good. So let's just go over some of those symptoms that you can get, at least with steroids, and that's particularly the case with very severe asthma. In those cases, you're going to need to resort excuse me, to oral or injected steroids. Now, prednisone is a prodrug for prednisolone. Prednisolone and prednisone are essentially the same drug. Prednisone is converted into prednisolone. Both of those are given typically orally. Methylprednisolone or methylprednisolone is only given intravenously. And that is typically for moderate exacerbations of asthma. So when you use systemic steroids, have lots, oral steroids like this, they have systemic types of side effects. So because these can double as glucocorticoids, they will tend to act like glucocorticoids. So one of the first things they will tend to do is increase the blood glucose levels. This can be really dangerous for patients who are diabetics. We're trying to keep their blood glucose level low and need to keep their blood glucose level low. So because corticosteroids induce gluconeogenesis in the liver, these drugs can do the same. So they can cause hyperglycemia. The other target of glucocorticoids, and remember, glucocorticoids bind to a glucocorticoid receptor inside cells, and they activate the expression of certain genes. Can you guys hear me all right with those fans up as loud as they are? Okay, that one sounds like a jet engine over there, but you can hear me, and that's fine. The other thing that these receptors activate are the alpha adrenergic receptors. So they tend to increase the density of alpha-1 adrenergic receptors. Now, think back from ENT, alpha-1 adrenergic receptors tend to be found in the smooth muscle of peripheral blood vessels. And when bound by epinephrine or norepinephrine, what do alpha-1 noradrenergic receptors do? What do they induce? Guys, you gotta know those receptors. Let's rehearse. Alpha-1, alpha-2, beta-1, beta-2. Alpha-1s are found. I just told you. Peripheral blood vessel. Peripheral blood vessel. Alpha-2s are found central nervous system. And they're autoregulatory. Beta-1s are found. Come on, somebody, please. Somebody guess, please. Thank you. The heart. They're found in the heart muscle. Beta-2s are found kind of all over, but the biggies. So blood vessels at the skeletal muscle. They're found in the myometrium. Found in smooth muscles that surround bronchial tubes. And they're also found in a few other places, those are the big, well, the liver as well. So if you activate beta-1 receptors, the heart beats faster, beats more forcefully. You activate beta-2 receptors, you will tend to relax smooth muscles in the respiratory tree. And we'll also see beta-2 agonists are also used to relax the myometrium. So they're actually used as a tocolytic, T-O-C-O-L-Y-T-I-C, tocolytic, to prevent contractions of the myometrium. It will also tend to activate vasodilation of blood vessels that go to smooth muscle, to skeletal muscle. So, because these increase the density of alpha-1 receptors, they will tend to cause vasoconstriction. Consequently, a side effect of these oral steroids is hypertension. Because they act like glucocorticoids, they're going to influence fat synthesis and fat distribution, and they'll cause fairly massive fat redistribution. So the other thing they'll tend to cause is truncal obesity. They'll also cause deposition of fat around the face. So you get something called a moon face. And then fat is redistributed to between the shoulder blades, causing essentially a large lump back here that's called a buffalo hump. Buffalo hump.
These are just systemic steroids.
These are the systemic steroids, yeah. So they essentially cause the symptoms of Cushing's disease. So hyperglycemia, hypertension, truncal obesity, moon face, buffalo hump. In women, they can cause hirsutism. Hirsutism means the growth of hair in places you don't want it, like on your upper lip. They can also cause mood swings. They can increase intracranial pressure and cause headaches. because they can affect the production of mucus in the stomach, they can increase the risk of peptic ulcers. None of these things sounds very good, do they? So, you're gonna give somebody these types of steroids, it's gonna be short term, right? Maybe go like this. Yeah. You don't want people to be on high dose steroids for a long period of time. So you're gonna use them to drive the asthma back to normal. Essentially, it's kind of a fire hose. You let the fire hose go in your house, you put the fire out, right? You also ruin a lot of things. Yeah? So this is the fire hose. So, nurses, patient's been put on, say, 40 milligrams of prednisone to drive their asthma back to where they can breathe normally. Just give me a shout out on the point you're going to shout out things you're going to watch. Weight gain. Blood sugar, very good. Blood pressure, good. Good, practical, tight and answer. Yeah. You can't, you know, put money on the last. It's gonna hurt. It's very frustrating to do. What else? Move, okay. I'm gonna ask them move. It's a tough one. Okay, you have history with the patient. You don't know what you do. No, I'm not trying to be mean, I'm just honest, it's so irritable. You've been short with people, that's okay, you know, we're friends. Right? Yeah, actually I have, I kicked the dog and I sleep on the left house and the radio. My neighbor and I got into a row, like an argument. And what have you, yeah, at dinner. What else? Yeah, that's a really good point, Debbie. So maybe you might want to measure waist circumference just before and after, and it starts getting unacceptably big, and then just maybe just have a look here and a look there, if they start moving forward a little bit. And if you use it really long term, these can also increase your risk of osteoporosis. That's it.
Are these only for people who like
Yeah, these are long term usually, but some of these, the blood sugar will actually jump up soon after you start getting. Elena, what else?
the unwanted hair growth?
Yeah. No, you guys got a big beard, you're not gonna tell. But in a lady, that's gonna be something that most ladies I know don't like putting. And if they're like, no, I gotta wax this thing again. Like that. Nothing more. Paige, how I do?
I don't think there is that maybe with our.
Yeah, okay, posture. Ascertain posture. Okay, good. These are things that, again, you're a nurse. Your job is to notice things. Notice things. Ooh. Other thing, I didn't mention this. It makes the skin thin, so you get easy bruising. That's important. And that you can just look at arms, look at legs, look at their back, so on and so forth. So leukotrienes are released by mast cells They're also made by eosinophils and basophils and macrophages. These are very potent bronchoconstrictors and very potent attractors of other white cells. So they will make the inflammation a lot worse. Consequently, preventing these from acting can be used to treat asthma. So here are the leukotrienes. You can see these are lipid-derived drugs. They're derived from membrane lipids. They're converted into the various forms, leukotriene B4, C4, D4, E4, so on and so forth. And the drugs that are available, two of them antagonize leukotriene receptors. So those are Montelukast. It went by the trade name Singulair, but it's now been available in generic for such a long time. Is generic even available? Yeah, yeah. Name brand's available still. That's surprising. It's been out for quite a while. This other drug, Zephyr-Lucast, is not available in the US. But if any of you work overseas, you will see this drug. It's not available in the US because it's not any better than Montelukast, and it's harder on the liver. That's why the FDA has not seen fit to approve it. So some of you I know are interested in possibly doing overseas medicine. And so Zephyr-Lucast is a drug we'll come across. Another drug that is used to inhibit the synthesis of leukotrienes is xylitol. And xylitol is not available in this country either, but it is available overseas. So the big drug here for this is Montelukast. Montelukast is very, very well tolerated. When you read the list of side effects, there are 1 to 2% sort of events. Things like dry mouth, things like headaches. They've been reported, but they are not at all common. So this drug is really, really, really well tolerated. It's used for seasonal allergies and is an add-on for asthma. Used for both. FDA just asked the manufacturer to add a black box warning. Apparently, this drug can cause depression. There's a debate as to whether it can cause depression or makes already present depression worse. That's difficult to tell, but the black box warning is there. So, one thing you're going to ask the patient before they go on this drug is, have you ever been depressed? Depressed so badly that I've been medicated for it. Because this drug can make it worse. And then when they're on this drug, you're going to ask them questions about depression. There are very good instruments online for depression that you can print out and have the patient do quickly. So there's a Hamilton Depression Scale, for example. Very easy, free, available online, that you can use to ascertain levels of depression. And this slide here simply shows you essentially where these things were. So as you can see, that enzyme up there, phospholipase A2, liberates the lipid arachidonic acid from membranes. That's inhibited by glucocorticoids. Arachidonic acid is then converted to prostaglandin H2, and that is the starting material for prostaglandins and for thromboxane A2. That enzyme, cyclooxygenase, is inhibited by NSAIDs, non-steroidal anti-inflammatory drugs. That includes things like aspirin, ibuprofen, all of your other prescription NSAIDs, Loxapam, piroxicam, indomethacin, ketorolac, blah, 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 all of those inhibit the cyclooxygenase enzymes. The lipo-oxygenase that converts the HP into leukotriene A4, that's inhibited by xylitol. And that's not available in this country. If you're on xylitol, you have to have regular liver tests, liver function tests, because the enzyme. The drug can cause some liver damage. In healthy people, it rarely does. These two drugs, montelukast, zafirlukast, they will antagonize receptors for these leukotrienes. That's how they work. And here is just a picture of the structures of those, which you don't need to know, but. So those are on page 5 of your handout. Notice that xylitol is a very rapid onset. Montelukast, you have to take it for a day or two before it starts to work. And headache's the most common complaint, and that's probably in about 2% of patients. It's not very much. And it tends to go away when you get used to the drug. All right, those are mainly the drugs that are available. How do you use them? Here is the treatment algorithm for treating the different types of asthma. So if you get your asthma classification ready. So if you do not have persistent asthma, you just have the mild intermittent asthma, you're only going to be treated with a fast-acting beta-2 agonist, a rescue inhaler, essentially. So the short-acting, it has a short half-life, and that's typically albuterol. That's the case if you have mild intermittent asthma. Once your asthma becomes persistent, you're now going to add a low-dose inhaled steroid. And which one do you pick? It's up to you. So Ticasone is picked a lot because it's available over the counter and it's really inexpensive. So fluticasone gets chosen quite a bit. So you will have the as needed short-acting beta agonist. You'll layer on top of that the low-dose inhaled corticosteroid, and that will need to be taken on a daily basis. Because remember, the purpose of that drug is to quell inflammation. The beta agonist is just to bronchodilate. It does nothing for inflammation. When you have mild intermittent asthma, inflammation is not a problem. When you have persistent asthma, inflammation is now a problem. And you always want to treat inflammation because, we said it last time, you want to prevent remodeling. To do that, you have to treat inflammation. All right? If that doesn't work, you don't get satisfactory results, you're now going to add, with inhaled corticosteroid, a long-acting beta agonist on top of it. So you're now layering another medication on top of that. And in your handout, there are several different combinations that are available that include bottom of page 5, you have a corticosteroid beta-2 agonist combination. And all these beta agonists are long-acting. So there's fluticasone and salmeterol. You have budesonide and formoterol, that's Symbicort. You have fluticasone and vilanterol, that's Braille elliptica. Mometasone and formoterol, that's Dolera. And then fluticasone, unifludium, and vilanterol, that's Trelegy and Lipton. So you now go to the added long-acting beta-2 agonist with the short-acting beta agonist as a rescue. You're going to keep this all the way through. All right, that doesn't work. That doesn't work. You're now into the moderate persistent asthma. Yeah.
What's the difference?
Step 1 and 2, you have to increase your dosage in order to get proper relief. If you're not getting satisfactory relief, you're getting incomplete relief. And if I might add, and you've been told this before, so I'll just tell you it again, because it doesn't hurt to hear it again. One of the biggest jobs you have as a nurse, besides managing side effects, is assessing if the treatment is working. What's your measurement, Lexi, if this treatment is working? If they're getting relief. So you're looking at FEV1s, you're looking at peak flow rates. And if those are normal, and the patient feels like they don't have limitations on their activity, maybe so go out and play, go from frisbee, they're still fine at work, what have you. People with newly diagnosed asthma very often have a lot of anxiety about work. Can I get fired? Having asthma attacks at work? You tell them, no, it's against the law. That's a lot because of the American with Disabilities Act, maybe. That's illegal. You can't do that. If they do that, I know good lawyer. In fact, I married one. No, sorry. I'm getting something. But here's their comment. Anyway, those are things that you can use to reassure patients. That get fired? No, you can't get fired. Number one, it's illegal. 2, we're going to fix this. Right? Positivity goes a long way, right? All right. Nobody wants to see a Debbie Downer in this, right? You got asthma. This sucks. You know what? You suck too. Life sucks. We all suck. Nobody wants to see a nurse like that. Okay, so now you're going to start to either increase the dosage, that is the number of times you use it, or you might need to up the dose of the inhaled corticosteroid to the medium dose rather than the low dose. You also can start to layer other medications on top of this. You can layer, for example, the leukotriene receptor antagonists. Those are oral. They don't need to be inhaled. If the patient's young and in good health, they have a good ticker, you can also maybe provide the awful one. Not the first choice, but yeah. Inhaled corticosteroid. Inhaled corticosteroid. So short-acting beta agonist, long-acting beta agonist. So you can bump up the dose or what have you, whatever. Bump up the number of times you're going to use it, and you can start layering medications on top of that. Now, if they get to step 5, where you're at, say, a high dose inhaled corticosteroid with a long-acting beta agonist, and maybe other drugs you've layered on top of that, and it's still not working, now it's time to consider a biologic. And we didn't mention the biologics before, so we'll mention them now. So if someone's asthma is of an allergic of asthma, their trigger is some sort of allergy, that triggers their asthma. So that means their asthma is very IgE sensitive. There is a medication It's a monoclonal antibody against IgE. It's called omalizumab. Goes by the trade name Xolair. This drug is very effective for people with allergic type asthma. Now, how would you know they have that? You order a RAS test, R-A-S-T, RAS test. The RAS test will determine the amount of IgE in your blood. If it's high, you have allergic type asthma. This drug is very effective under those cases. This drug is also safe in children. So it's also used in children a good deal, and it's very effective. This drug is expensive, unfortunately. Cost of a single treatment. So that is a pre-filled syringe. You inject it once every 4 weeks. It's $1,000. It's not cheap. So when's the insurance going to pay for that? Tried everything else and it's not good. Then you usually pay for it. So it comes in this kind of cool little container like that with a pre-filled syringe. Kids really like it because it's colored. In fact, the company actually makes it with little cartoons on it with little bears chasing butterflies and things like that. So kids, of course, well, adults don't like needles either for that, but kids usually really don't like needles. So the parents may, in fact, this is a way to earn some extra cash. Parents may call you and say, you can give my kid an injection. And you might say, well, sure. My time is precious. It may be your friend who may do it for them, that's fine. Or you may say, yeah, okay, I'm going to charge you because this is my profession and I'm giving them my time to do this. And just have a price in your head. And if you don't want to charge them very much, that's fine. Or if they're on Medicaid or something like that, and you don't want to, that's fine too. Just in your mind, decide what you're going to charge them. Don't let them talk you into a price or something like that. But if you're not going to charge them, then don't let them force money on you. Agree ahead of time what it's going to cost. All right? That'll also keep you from being taken advantage of as well. People sometimes can take advantage of goodwill. I know a lot of you have a lot of goodwill, so I don't want to see you being taken advantage of. So this drug binds to circulating IgE. It will interfere with receptors that bind IgE on various types of cells. It decreases circulating eosinophils and it decreases mediator release. And again, it's very effective. Now, these two drugs are used for allergies, but they're also good for allergy-induced asthma. So these are mast cell stabilizers. Mast cell stabilizers. These bind, well, actually, they enter the mast cell, and even if the mast cell gets cross-linked with IgE and antigen, the mast cells don't dump their granules. So these are preventative drugs. You can't use these to arrest an asthma attack. They're used to prevent an asthma attack. So cromolyn sodium is the main drug in this country. Natocromil, the manufacturer discontinued it in this country, but it's still available overseas. These both work the same way. They're preventative, prophylactic. You can't use them for a raging asthma attack. They use to prevent an asthma attack. These are also available as eye drops or to prevent ocular allergies as well. These are typically used in combination with other medications because they're not all that effective. But when layered on top of other meds, they can be effective. So if your asthma is of a eosinophilic isotype, then there are particular medications, biologics, that are extremely effective. So there's a group of drugs that inhibit interleukin-5. Remember, interleukin-5 is released by T helper 2 cells. That recruits eosinophils, and it's an eosinophil mitogen. It causes eosinophil proliferation, and it causes the bone marrow to make more eosinophils. So a couple of these drugs inhibit the interleukin-5 receptor. That's benralizumab, goes by the trade name Fasenra. Then there are 2 drugs that will bind to interleukin-5 and prevent it from acting. And these are reslicumab and mepolizumab. They go by the trade names Sincare and Nucala. Now, reslicumab is only available intravenously. You have to come into the doctor's office and get this infused in. You can't take this at home. Both mepolizumab and benralizumab come in injector pens that you can inject subcutaneously. So you can self-administer the drug. These drugs, again, they're antibodies. They're very expensive. Insurance won't pay for this unless you have demonstrated that someone has the eosinophilic subtype of asthma and they are not sufficiently treated with other medications. Then insurance will pay for it. And these drugs are very, very effective for that. But again, they ain't cheap. Benralizumab is injected at first once every month, and then after the initial treatment, you give it once every 2 months. One treatment, one set of injector pens for 2 months, it's $5 grand. Not cheap. Mepolizumab is injected once every month. One injector pen for the month is $3 grand. Reslicumab, you get an infusion once every month. That's a little under $3 grand. So these treatments, they ain't cheap. But if you have that type of asthma, these drugs are remarkably effective. There's a new medication also that inhibits interleukin-4 and interleukin-13. Interleukin-4, remember, also helps induce B cells to make IgE. And interleukin-13 is one of the cytokines that acts on smooth muscle. Turns out these 2 interleukins share a common subunit. And this antibody is made against the alpha receptor subunit. So it inhibits interleukin-4 and interleukin-13 signaling. This drug is called dupilumab. This drug is also FDA approved for atopic dermatitis. Atopic dermatitis. Can you write that down? No? Okay, atopic dermatitis. And it's also approved for this eosinophilic esophagitis, where you get this horrible inflammation of the esophagus, and when you biopsy the walls of the esophagus, they're loaded with eosinophils. This is the first drug available to treat that awful condition. So here's how it works. It works on this particular subunit of this receptor. Prevents interleukin-4 and interleukin-13 signaling. And in the Liberty trials, in patients as young as 12, this drug did everything you wanted it to do. Decrease circulating IgE, decrease asthma exacerbations, decrease eosinophil counts, decrease dependence on oral steroids. Most of the patients on it were able to go completely off oral steroids, reduced marker of inflammation, and was quite well tolerated. This also comes in injector pens that patients can self-inject. This drug is given once every 2 weeks. The cost of a month's worth of doses is $3 grand. That's not cheap either. But these drugs work. They work quite well. So now you consider a biologic. You have to properly isotype classify their asthma. And if it's the eosinophilic type, you can go to the biologics, or if it's an IgE type, you can go to omalizumab or something like that. So I think, yeah. So these are on page 4 of your handout. So there's another drug, it's really new. It came out towards the end of last year. And it's called tezepelumab, Tezspire. And it hits an even earlier mediator of the asthma pathway, the thymic stromal lymphopoietin. There's just not a lot known about this drug. So I gave you essentially what came out in the medical letter. And I'll just let you read that. You'll learn more about this drug as it gets used more. Because it will get used more. Again, fairly well tolerated, but with its set of caveats. All right. Let's take a break. We'll come back, look at asthma exacerbations, and then how to treat them. If say a patient comes into the ED, they're really sick. I can't breathe, they're suffocating to death. What do you do? And then we'll move on from there to blood pressure medicines. Okay, let's take 5.
Dr. Baranovich,
Yes, ma'am.
our PowerPoint isn't updating. At least mine isn't. I don't know if theirs is.
Okay, let me see if I can fix that.
Okay, thank you.
Okay, so click here. Click here. Okay, click there. Okay, now does it move?
It's still just stuck on the increasing asthma.
Oh gosh. Now does it move?
Yeah.
Then I'll just keep it like that.
Okay, thank you.
I don't know why Zoom does that. It does that sometimes. It seems to depend on the PowerPoint. I've not at all figured it out because Cynthia tells me to click on the slide and then do it, but it still won't advance. So
Well,
I'm
thank
not at all clear what's going on. Okay, so it doesn't move. Is it moving?
Right now it's stuck on like a loading screen. I don't know if that's just mine.
Okay. It's still loading?
Yeah, I can see the PowerPoint, but there's just like a blue circle in the middle spinning.
Blue
Yeah, it's
circle in the middle.
Yeah.
Okay, let's try this again. Let's stop share. All right, slide up. Yes or no?
No, it's not working.
No. Is it moving?
No.
Okay, then forget this. I'm just gonna stick here. No, I'll just keep it there. That should work. I'm sorry about that, but I don't know how to fix it.
Okay, thank you.
So let's do 21 unit test, are we getting those? Or are you just gonna rack and fill it?
I doubt it. We don't have 21 weeks in the semester. So,
Or gonna just make them?
yeah, I'll prorate it.
The what?
Prorate it.
Okay.
Yeah.
So like, make them.
Yeah. With luck, we'll get like 12.
For the dosage calculations, it asks us to like take a picture. Of
Mhm.
the- Can I just like do that? I don't have like syringes to take a picture of.
You can't go get syringes across the street.
Probably not. I mean, I guess I haven't tried, but
Okay, guys. The drug calculations ask you to fill a syringe and take a picture of it. You can get syringes across the street. Go see Miss Emily across the street. That's it. And just say, look, drug calculation, I need to fill a syringe, take a picture of it. Can I use the syringe, please? She's got a ton of syringes up there. Still asking. The point of this exercise is to make sure you know how to do the syringe. You'd be surprised how many nurses can't read a syringe. So, yeah, calcium plugging happens if you say, really? Yes, really. So I want to know that you guys know how to read the syringe. So calculate it, fill it, take a picture of it. Just go across the street. You have lots of syringes. So, because if you don't have the right answer, if you did, we did it right, but you know, add or subtract it wrong or something like that. You'll get most of the credit. Won't get full credit, we get most of it. You just give me an answer that's wrong, then that's all this is bad.
I did it, I'm scared I did it wrong, but you know, that's all.
Actually, the best way to make sure you get it right is to do it with friends. You guys all get the same answer. Either you're all completely lost or there's a good chance that you guys all get it right. So
That's gonna happen.
just put put the big picture. Now it's happening.
Yeah, my mom. That's fine.
I may use some just. Those just completely cover it, so. Many and I are discussions on. It gives them some ATI. Second, they're really expensive, and then the test, if I gave a test for one, it's not too hard. And students get picked on, and the students get picked on. The motivation to learn stuff, all like a. So I'm thinking there's another basic science, program called osmosis. That has a nursing program that's cheaper than amazing. Right, because you guys on osmosis for the first 2 years, then transition to group one. The state university of London, I'm sure if you're most of the videos in class. And they have tests and in fact, you guys, so the video the virus. Because in my group have to get this and down and do all that. You doing it, you know, this one's good. It's got MP sections too. And then, it's, have you guys on it, it's like $10. It's then we just do ATI for the last 2 years, and worry about the actual different rates we have. ATI is great, it works, but it's meant to be used for that 2 years. We use it now. They used it last year, and people kind of got like, it's hard, and I'm getting frustrated, and I'm getting mad, I don't want to get mad, I should be mad at you. You made us do it. We're just like, well, I want to go straight into the yes. So, the thing was to do that we did tonight, just it on the, so, my concern is that I'm worried that you guys would not really study. I'm just trying to study things. Sorry? You're nervous, laugh.
There's. You have to kind of laugh, there's so much information.
It's like,
It's a lot.
it's like other prisons. So my wizards just, they just study this one, they don't do anything with the previous stuff. Then by the time we get to Matthew, they've forgotten all of this. So it's kind of the same sort of thing.
What, like 10 times? Yeah. Yeah.
I don't know, memorizing versus academic thing like that. Not easy. Trust me, I did it. Well, those parables in chapter 13, it's easy to get them mixed up.
Dr. Baradovich,
Yes.
are you giving us the quiz online or are you gonna have us take it with the,
Do you want me to email it to you? Do you want to take it when you come back? What would work best for you guys?
could you email it so I can get it done?
Do all three of you want me to email it?
Yes, please.
That's
Yeah,
what I'll
if you
do
can.
then. I will email it to you. I probably won't remember tonight, but I'll try to do it tomorrow. And if I forget, by Friday, if you haven't received it, send me an email to remind me, okay?
Okay, thank you.
Yeah. All right, let's resume. All right, let's say you graduate and your first job, say, is in the ED. Maybe not your first choice, but that's where the job was, so you become an ED nurse. Then maybe you'll do L&D or med surg or psych or whatever else you actually have your heart set on or whatever. Or maybe you want to be an ED nurse. Okay, Jennifer wants to be an ED nurse, so this is her bread and butter. So in this case, a kid comes in and a kid says it's suffocating. There's really no time to do any sort of the peak flow tests. So patients, they can be so short of breath, you can't even really get a history from them because they can't talk in full sentences. So with acute asthma exacerbation, the priority is to relieve the current episode and then figure out what the patient needs to send them home so that they're not back in a couple of hours. Or you may need to send them to the ICU. So that essentially is your decision tree. Can I stabilize them and give them something to keep them on the straight and narrow respiratory wise? Or do they need to go to the ICU? So that's kind of your decision tree. And unfortunately, ED nursing is a lot of that, a lot of triage and decision and so on and so forth. So the best initial test is a peak expiratory flow rate test. It's the fastest, hardest a person can exhale after a full inspiration. It's like a bedside mini peak flow test. Not quite as reliable, but really useful in an emergency setting. So that's the peak expiratory flow rate. So that's a test you can do really quickly. You're then going to look at the predicted peak flow for the patient's age. There are charts. You can bring them up on your phone easily. And once you bring them up on your phone, you're going to ask, is it greater than 70% of the predicted flow rate for the age of this patient? Now, in the clinical setting, you're going to previously classify the severity of asthma based on symptom frequency and forced expiratory volume in 1 second. Also, activities that will determine the patient's long-term treatment. In the acute setting, you're going to classify asthma exacerbations in either mild, moderate, or severe. Mild, moderate, severe, or life-threatening and near fatal. Mild, moderate, severe, life-threatening, or near fatal, and near fatal. You're going to classify that based on the severity of the current symptoms and the peak expiratory flow rate. You can also do an arterial blood gas. For that, you got to draw blood and send it to the lab. May not have time. It's a useful test. So an ABG, arterial blood gas test. Useful, but time is of the essence. So let's look at mild exacerbations. We have the slide up here. I can't make it full screen because if I do, the people on Zoom won't be able to see it because something's funny with Zoom or something. So let's take a look at that. You have normal alertness, slight tachypnea. What's tachypnea? Devin, what's tachypnea? Fast rate of breathing. Very good. Huffing and puffing, essentially. Fast tachypnea, they have expiratory wheezing only, not wheezing on inspiration, just on expiration. They'll have a mildly prolonged expiratory phase, kind of a 1-to-1 rather than a normal 2-to-1. Minimal accessory muscle use and an oxygen saturation of 95%, usually above 95%. So with mild exacerbations, you have a peak expiratory flow rate of greater than 70%. People with mild exacerbations rarely end up at the ED. Most of the time, their symptoms go away with a rescue inhaler puff. So these in the ED, you're not going to see them very often unless they've got something else going on and they have mild asthma as well. In that case, do you have your rescue inhaler? Take it for me, please. They don't have the rescue inhaler. Let's get the kids some albuterol and call it good. Moderate exacerbations are characterized by symptoms that don't readily improve with a puff from the rescue inhaler. That's a big difference. So as you can see here, we have again, normal alertness, tachypnea, wheezing throughout expiration with or without, excuse me, inspiratory wheezing. Significant use of accessory muscles to breathe. That's a big difference between this and mild exacerbation. Oxygen saturation now is below 95%, but not below 92. So it's between 92 and 95%. The peak expiratory flow rate will be between 40 and 70%. Mild and moderate exacerbations, you usually don't need an arterial blood gas, usually. Severe exacerbations. Now we have an inability to repeat a short phrase. Think of a short phrase. You might have a kid repeat back to you. Could be a nursery one. Think of one. Who has one? I think of the Byron poem. The Syrian went down like a wolf on a foe, something like that. It's a Byron poem. I like Byron. Okay, he was in the mall womanizing crap, but I still like his poetry. The Syrian went down like a wolf on a foe. It could be little in this month that's out on a topic. Eating her Persian way. It could be star light, star bright, first star I see them. It could be, for God so loved the world, it could be whatever. Okay? Think of something you have a kid say back to you. Can they say it back to you? You can't say it back to you, now you're thinking severe. Severe. Extreme tachypnea, they're really huffing and puffing. Both inspiratory and expiratory wheezing. Significant use of accessory muscles. Oxygen saturation is below 92%. Below 92%. So mild, we're above 95. Moderate, we're between 92 and 95. Severe, we're below 92. Below 92. Signs of impending respiratory failure, like cyanosis, inability to maintain respiratory effort, depressed mental status, respiratory acidosis, so on and so forth. Now you can see you need an arterial blood gas at this point. So with severe exacerbations, your peak expiratory flow rate is going to be between 25 and 40%. Respiratory rate will usually be greater than 25 breaths a minute. What's a normal breath rate usually? How many breaths per minute? This is a number you should know. That's yes. Right? I think it's 20 breaths per minute. That's what they know. No, 90. What's the other? What's the other? Right? No, really, too high. Try 12 to 16. 12 to 16. Someone's older, the wax is a little stiffer, maybe 18. Someone's over 20, that's a 50. And this time it's over 25. They're huffing and puffing. They're really huffing and puffing. Heart rate greater than 110 beats per minute. Patients unable to complete sentences. So if you get an arterial blood gas in moderate and severe asthma exacerbations, your low partial arterial pressure of carbon dioxide should normally be between 33 and 45 millimeters of mercury. If, however, you have the severe rate of breathing, then you're going to be losing a lot of CO2. Now your CO2 is going to be a whole lot lower. that breathing out of CO2 is going to shift the acid base balance in your body away more towards alkalosis. All right, so first thing you're going to do is you're going to start supplemental oxygen. You're going to get an oxygen tank, put a cannula in their nose, turn it on. You're trying to get their oxygen saturation back to 92. That's the first thing you're going to do. So supplemental oxygen. You start a nebulizer, usually with albuterol. In severe cases, you're going to combine albuterol with ipratropium. Ipratropium. And if you're dealing with a kid, unless they're a frequent flyer when it comes to asthma attacks and they've been in the ED before, they may not know how to use a nebulizer. You need to make sure that they're using the nebulizer properly. Always check that. Always check that. Next, you need to deal with the inflammation. What are you going to use to deal with the inflammation? Corticosteroids. Corticosteroids. You can give either oral or intravenous systemic steroids. If the patient is near respiratory collapse, you can also give, and this is usually given IV push, magnesium sulfate. Magnesium sulfate is going to go into the smooth muscle and it's going to prevent calcium influx in the smooth muscles. That will cause bronchodilation. If the patient gets back to normal, you're going to send them home with a brief oral course of corticosteroids for about 5 to 10 days. Oral corticosteroids, you always step people off corticosteroids. You never stop them cold turkey. You know why? Corticosteroids cause adrenal suppression. You take them off the steroids cold turkey, they're going to start to have symptoms of adrenal insufficiency. Which is why you step them off and let the adrenal glands get back to normal. Otherwise, it's not going to be pretty. If the peak expiratory flow rate is between 50 and 70%, you can't get it back to 70%, the patient will need to be admitted. And if it's less than 50%, they need to go to the ICU. And the patient may need to be intubated. So that's your algorithm there, is that peak expiratory flow rate. You can get it back to 70 and go home. From 50 and 70, they get admitted. Less than 50, ICU. Percent. Remember, the peak expiratory flow rate, take that number and compare it to the expected number for the give it a percentage of that. if it's 70% of that number. And again, these are numbers, the hospital will probably have these posted somewhere, or you can just get money. Or some nurses carry these little tables that are scrubs, just pull stuff like that out and they, oh, okay, okay, so you're at 40%, or you're at 20%, or you're at, whatever. So this is the algorithm essentially that we just went through. And I realized that writing is very small, but if I make it bigger, then the people on Zoom can't see it. And the nebulized albuterol ibupropium, that can be given every 20 to 30 minutes. You could also use epinephrine or terbutaline. Both epinephrine and terbutaline are going to cause their heart to beat really fast. They'll have palpitations, that's to be expected. Good response, then you approach the patient as needed. Poor response, then you go with IV methylprednisolone. Switch to nebulized, blah, 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 then IV mag sulfate and what have you. IV terbutaline if you need to. And yeah, that's a treatment algorithm. All right, any questions about asthma? Any question about any of the drugs we've talked about? All right. Can you look at someone and tell that they have high blood pressure? Can you walk outside and say, you know, my blood pressure is high? So blood pressure is one of those things you don't know if it's high or not. You can't just look at the patient and say, oh, you've got high blood pressure. So high blood pressure is silent. High blood pressure, however, has some pretty serious consequences. So you might remember from pathophys that high blood pressure will cause the smooth muscle of arterioles to enlarge, and it will cause the arterioles to cinch down. And in the brain, it can actually squeeze protein and other things into the layers of the arterioles and cause this arteriolosclerosis that makes the blood vessels very fragile. It increases your risk for a stroke. It can cause the heart to enlarge. And it can put you at risk for hypertrophic cardiomyopathy. That can set you up for heart failure. None of these things are good. Also, the vasculature in organs can undergo damage and fibrosis and things like that. It increases the rate at which you'll make atherosclerotic plaques. The retinas of your eyes, those vessels get narrowed. You get tissue skin near the retina. You start to go blind a lot earlier. Increase your risk of glaucoma. The list goes on and on and on. High blood pressure is bad. It's bad. So it needs to be controlled. Hypertension in the US is the most common primary diagnosis. 35 million office visits have as a primary diagnosis hypertension. 50 million or more Americans have high blood pressure. Worldwide, something like 1 billion people probably have high blood pressure. 7.1 million deaths per year attributable. It's the one way or another to high blood pressure, directly or indirectly. So have I convinced you this is a problem? Yeah. You guys will be trained to take blood pressures. In many offices now, the machines are being used. Make sure the machines are calibrated. Also, make sure that the cups are the right size for the patient. I can't tell you how many times I've gone into the office and put the kit cup on me. And we're starting to pump it up. Uncle, oh, yeah. It hurts, it hurts, it hurts. Please don't do that. It's really painful. So make sure the cuff you're using is the right size. For someone, if you get some weightlifter dude, the standard cuff may not fit them. And the blood pressure may be chronically high. There are big cuffs for weightlifter dudes. Make sure you use appropriate size cuffs. When you pump it up, and you're listening, it's common. Patient is nervous and they try to talk to you. Once you get that stethoscope in there, it's kind of hard to hear anything. The MA always tries to talk to me, but I know full well they can't hear me. How are you doing today? I'm just kind of nodding to this. When you pump it up and you can't hear the cough sounds anymore, let it out slowly. Don't go. Oh, your blood pressure's fine. Okay, why don't you do that again? Let it out slowly. You hear the first sound. After systolic, you wait till the sound goes away. Diastolic. Do it slowly, gradually. If you're not confident about the first reading, just pump it up, do it again. There's no shame in that. Oh, I think I know what it was, but here, let me just check this, make sure. Typically, you want to do 2 measurements and average them. And always tell the patient your numbers. Don't, oh, your blood pressure's fine. Okay, great. What is it? Tell the patient their numbers. Tell the patient their numbers. And please try not to be judgmental. Because some patients going to the doctor's office, they get really nervous. Their blood pressure will be high because they're nervous. So, in fact, if it's high, just say, it's a little high. Let's do some other things. Maybe come back to it, take it again, and what have you. So, the old standard used to be that the blood pressure, if it was 140 systolic, it was high. That's been revised down. It's now 130. Above 130, you have grade 1 hypertension. Used to be 160. With grade 2 hypertension, now it's 150. Diastolic really hasn't changed. If it's between 80 and 90, that's usually grade 1. If it's 82, usually a doctor trying to get that notice. Above 90, then usually that's your grade 1 hypertension. If either the systolic or the diastolic are above the recommended level, you have hypertension. You have hypertension. And so say it's between 120 and 129, that's so-called pre-hypertension. That's not a disease category, it just means that the blood pressure needs to be watched. And your blood pressure throughout the day cycle, it varies. So let's pick on our soccer players. Let's say Melina comes off the pitch after running back and forth many times. She comes off the pitch. Page one. Make it proud. That exercise is causing massive vasodilation. We're going to take your blood pressure at that time. It's going to be in the cellar. It's going to be low. However, if Melina walks into my class and I hand her a test, I bet you her blood pressure is going to be higher. Your blood pressure cycles throughout the day. That's normal. What you're getting when you take the blood pressure is a snapshot. You're trying to see if it's within a certain range. That's why if it's high, it's perfectly reasonable to just retest it. People who get older, the veins stiffen as you get older. So that can lead to something called isolated systolic hypertension, where the diastolic pressure is pretty good, but the systolic pressure is a little high. That is common in older people, but that still warrants treatment usually. This table here shows you that the rate of isolated systolic hypertension increases as you get older, to the point where once you get in this age range, your chances of having isolated systolic hypertension are pretty good. That's the reason why many of you are CNAs and you work at retirement homes, and a lot of those patients are on blood pressure medicine. This is why. It's just one of the blessings of old age. I've seen my blood pressure creep up as I've gotten older. It's just what happens. And so my doctor says, your day is coming, which I know he's probably right. So if people come into, say, the hospital, and your blood pressure is really high, a hypertensive urgency is a really high blood pressure, but there's no sign of end organ damage. Hypertensive emergency is a really, really high blood pressure, but there's no sign of end organ damage. Hypertensive urgencies used to be treated aggressively, not the case anymore. If someone sees fine, the trend now is to just kind of let it go and tell someone to lay off the potato chips or something like that. Hypertensive emergencies, on the other hand, those usually require aggressive treatment with emergency antihypertensive medications, which we will talk about. All right, this is a good place to stop. Monday, remember, we're still meeting. Some of you told me you won't be back by then. And you guys got Zooming is an option if you won't be back by then. I'd rather you come back safely rather than rush to get here and risk an accident. So I will leave that to your discretion. The whole class ends up wanting to Zoom. So, happy Easter to all of you. Celebrate the resurrection of our Lord with the gusto and the reverence of His words. Be safe, come back safely, and tell your parents you love them. If they never tire of hearing it, I can tell you as a parent. Okay, gang, we're done for the day, so happy Easter to you all. And I'll see you hopefully Monday. All right?
Sure. Happy.